Are my slides visible? And is the slide changing now? This is the problem with what do you say, the Google Meet, because when we share a window, slides may not change. Is it visible now? And is it changing? Okay, okay. Okay, so let us look at Ayurvedic research, current avenues, and emerging trends. And if at all, if my connection goes off, please call me, madam, because in Google Meet we may not be able to see the participants and all those things, just like in Zoom. So if at all, if there is some interruption, please call me by my phone. So let us speak about evidence-based medicine. So most of you might have heard this term evidence-based medicine, right? So let me take an example. Suppose we have a patient with Jora. A patient came to you with dengue fever, who is a 35-year-old female with a history of dengue for the last 5 days. So now we have to treat the patient with Ayurvedic medicines. So usually what as Ayurvedic doctors we are accustomed to is to go back to the Samhitas, read the Samhita, read the slokas regarding the Chikitsa, and select some of the medicines from that, and then we give to the patient. But this is not exactly evidence-based medicine. Evidence-based medicine means once you get a patient, a typical clinical situation, you look for the evidence in the published literature, so that you look into various recent publications in authentic journals, and you look into the specific case scenarios where a patient, especially middle-aged female, who has been treated with Ayurvedic medicines, who is suffering from dengue fever, and you search through the articles and you select the most valid ones, and then you select the treatment which is available, which is explained in that relevant article, then you give that to the patient, and then you get a result. This is something related to evidence based medicine, so that you don't practice based on what is told in the textbooks, but you practice based on the evidence that is available in the published domain. So actually evidence based medicine is a 5-step process. Those who are interested, you can go and read later on. Okay, so the definition is a systematic approach to finding and analyzing published data for the basis of clinical decision making. This is the actual spirit of evidence based medicine. And this term has been coined by Gordon Guyat in Ontario in 1990. Actually, if you go through the eras of evidence based medicine, actually, there are, if you look at the historical aspect, there is an ancient era, the transitional era, and the Renaissance era. And we are in the Renaissance era now, as far as evidence based medicine is concerned. But coming back to Ayurveda, suppose I got a patient with rheumatoid arthritis, a male, 40-year-old male with rheumatoid arthritis. And if I go and search the published literature, do you feel that we get a lot of valid publications? Actually, no, we don't get it, because we don't have the habit of publishing such type of studies. Even our studies are not valid because we don't follow the proper methodology. Of course, recently there has been changes and there has been some good studies as well, but it's not widespread as far as Ayurveda is concerned when you compare this with that of modern medicine. If you look at the modern medical field, they have evolved into this evidence-based practice since last so many years. I can say that 30 to 40 years they have been evolving into the evidence-based medicine. So they don't treat the patients based on what is told in the Harrison's textbook of medicine. Always they look at the recently published data. What is the recent evidence? So this is where we have to go forward, because without evidence, for example, we say that Chavanaprasha increases lifespan. Why we say? Because it is told in Charaka Samhita. Is that data valid now? No, that data is not valid now, because we don't know the Chavanaprasha which acted at those times of Charaka Samhita, whether the what do you call the effectiveness of that yoga is still relevant. We don't know whether even if that yoga is effective, we don't know whether it is effective in the current population with the current what you call prakriti and all those stuff. We don't know, we have not studied. So we cannot just sleep on what is told in our samhitas and we can just keep on giving medicines to the patient. That's not possible. So we have to generate evidence. So this is where uh, we have a very big role to play. So whenever we speak about evidence, there is a ranking for the evidence. So rank 1 means a high quality evidence and rank 5 means a low quality evidence. So that there is something called as an evidence pyramid. I think most of you might have studied research methodology in the final year syllabus, because the recent syllabus they have the research methodology. And if at all you have studied that, you might be familiar with the evidence triangle. We will discuss later on. So the ranking is based on certain parameters, including the study design, the quality of the research, validity of the research, and methodology that is adopted in the research. And accordingly, the evidence is being ranked. And if you look at this evidence pyramid, you can see the bottom end of the pyramid is the level 5 evidence. That means it's a weak evidence. So you do a survey among physicians. You take an expert opinion. For example, I'm an expert of 17 to 20 years in Ayurveda. And you get a patient with rheumatoid arthritis and you take my opinion. Then it doesn't have much evidence value, because it belongs to the rank 5 of the evidence triangle. Next comes the case reports and case series, where you publish successful case reports. And then comes the case control studies, and then come cohort studies, and then comes the messiah of what you call studies, that is the randomized control trials or meta-analysis. You will be introduced to each of these terms if at all you have not been introduced in the final year BMS. In the current curriculum, you have 6 months full dedicated to study research methods. So in that study, you will be exposed to something called as what is the evidence pyramid. So now we know that the level 1 evidence is RCT and the level 5 is surveys, and all the others fall in between these. So coming back to Ayurveda, how can we generate such evidences? For example, I have treated a series of patients, for example, say 10 patients of rheumatoid arthritis with Pippali Vardhamana Rasayana. Vardhamana Pippali Rasayana. Now, what I'm going to do is I am publishing a case series that I did this Pippali Rasayana in 10 patients and I got such and such results. And if I publish that, then it becomes somewhat valid evidence so that other practitioners can look into my published data and they can practice, they can also implement that in their clinical practice. But for a fully valid data, you may have to go for a randomized control trial. We'll discuss that later on. So I hope you got this. So that is where the research comes into play. If you want to generate evidence, you have to do research. So then now the next question is, what is research? Research is nothing but systematized effort to gain new knowledge. So whenever we feel that there is something lacking, whenever we feel that there is something lacking, then we have to do the research to fill that knowledge gap. So you identify a knowledge gap, and in order to fill that knowledge gap, you do research. So a research can be considered as a careful investigation or inquiry, especially through search for new facts in any branch of knowledge. So only thing is that there should be some knowledge gap that you are trying to fill. Depending upon the objectives of the research has been classified into several categories. I'm not going in depth into this. You can look into this later on. For example, there is an exploratory research or a formative research. Depending upon if at all you want to get new insights into a problem, then it's called as an explorative research. If you want to describe some phenomenon, for example, 2 years back COVID-19 happened. So now you need to describe what are the dosha predominance that you have found in COVID-19 patients. Then it becomes a descriptive research because you are observing and you are describing a phenomenon. This is called as a descriptive research. Then comes something called as a diagnostic research, where you look into the causes, you look into the frequency of a certain manifestation, you look into the causative factors, etc., etc. That becomes diagnostic research. And then comes hypothesis testing research. For example, you described that COVID-19 has vata pitta predominance or something like that, or vata kapha predominance, something like that. Now you are generating a hypothesis that a particular kashaya, maybe Dashamula Kadutraya kashaya, is effective in tackling the respiratory features in COVID-19. Suppose you are generating a research hypothesis. Then you are going to do a clinical trial to test that hypothesis. Then such researches are known as hypothesis testing researches. So these are some examples. There are a lot of classifications of research that you will come to learn in the coming days. So there is something called as a scientific method where you generate questions, you ask questions. Suppose we don't have a very good effective drug for treating diabetes in Ayurveda. So this is a problem now. This is a knowledge gap where we don't have a very effective drug to treat diabetes. Then now what we will do? We will go for a literary research where or a literature search where we skim through published literature to know what has been already done in this regard. So I give some keywords into the search database, diabetes, Ayurvedic treatment like that. Then you search for the available literature. You go through that and identify the knowledge gap. And after knowing that what has already been done, then I will know what is to be done next. What is the knowledge gap? Then I will generate a hypothesis. I will do an experiment to test that hypothesis. I will gather data, I will analyze the data, then I will put out the result. So this is known as a scientific method. So there is something called as an hourglass notion of research, where a research always starts with a very broad question. We don't have an effective drug in diabetes in Ayurveda. This is a broad question. Now, how can you make it more specific? We can make it more specific. Is Chandraprabha Vadi effective in bringing down HbA1c values in people? Now, the broad research problem has been formulated into a specific research question. So now we are coming to the neck of the hourglass. And then we do the clinical trial, we collect the data, and then we analyze the data, then we get some findings. After getting these findings, we extrapolate these findings to the general population so that in this age group of population, Chandraprabha was found to be very effective. So this may be a very good drug in a general population for diabetes. So this is something called as a scientific method where you generate a hypothesis, you do an experiment to test the hypothesis, you analyze the data and come to a conclusion. I hope this is clear, the scientific method. So as I told, there are several types of research like descriptive and analytical, applied and fundamental, quantitative versus qualitative, conceptual versus empirical. A lot of this you will come through in the coming days. But coming to research in medicine, basically the study designs can be classified into two. One is an analytical study and a descriptive study. So let us take an example to understand this. Suppose we assume that excessive use of pickle leads to amlapitta. This is our assumption. Excessive use of pickle leads to amlapitta. So now we can study this hypothesis in various angles. For example, we can go for descriptive studies where you just observe patients with amlapitta. So a lot of patients comes with amlapitta to our clinic. You just ask one question: Are you taking pickle or not? Do you have a history of taking excessive pickle or not? So here what happens is we are just looking at the patient population at one point of time. There are no further sittings or further exposure to the patient. You just do a cross-sectional analysis. So this is a descriptive study where we just tell that out of 10 patients who came with amlavita, 8 of them were using excessive pickles. So this is a description. You are not giving any drug. No, what you call intervention is done. So this is a cross-sectional study. Then I have already told about case reports and case series. So all these things are descriptive studies where you just describe something. You are not going into in-depth analysis, etc., etc. You are just looking at the pattern. What is the pattern visible? What is the pattern available? Or in case of case reports, we were routinely treating a patient with a particular medicine and suddenly you got a very good result. So now you are publishing that as a case report. So these are called as descriptive studies. Even though they don't have enough evidence value, but they are the cornerstones of further research. So these descriptive studies will help us to formulate or develop new hypotheses so that we can go into the analytical studies. So next comes the analytical studies. You can see on your left hand side. So analytical studies again can be classified into observational studies and experimental studies. Observational study means the researcher is not actively intervening in the population. They are just observing the population. For example, case control studies. You have cases of amlavita and you have patients without amlavita. So now what you are doing is you are just asking one question to both of this population. Did you have a habit of taking excessive pickle? So you're asking to case which is amlavita and you're asking to controls which where the patient doesn't have amlavita or individuals who don't have amlavita. So now you will get a data. Out of 100 patients with amlavita, this much number were taking pickles, and out of 100 patients without amlavita, this much number was taking pickles. So such studies are known as case control studies where the outcome has already happened and you are looking back retrospectively. But there is another possibility for us. Why don't we follow patients, individuals who take excessive pickle, follow them forward and see whether they are developing amlavita or not? So these are known as cohort studies, where cohort means a group of people who shares a similar characteristic feature. So people who are smoking is a cohort. For example, we are a cohort because we are Ayurvedic students or we are Ayurvedic scholars. So we are a cohort because we share a similar characteristic feature, that is, we are belong to the field of Ayurveda. So like that. So cohort means a group with similar characteristics. So these studies are known as cohort studies. You follow up individuals who smoke continuously, you follow them forward and see whether they are developing cancer in the future or not. So this is known as prospective studies or cohort studies. So here what the difference is that we are not actively intervening. We are not forcefully forcing them to take pickles. They are taking pickles, we are just observing them. We are not giving free cigarette packets and we are asking them to smoke. No, they are smoking already, so we are following them forward. So these studies where we don't intervene actively are called as observational studies. Then comes experimental studies where we give some intervention, we give pranayama, we give yoga therapy. Wherever we do something to modify the behavior, diet, medications, etc. of individuals, wherever we intervene, they are called as experimental studies. So this is a basic classification of research designs that we can use in medicine. I told this because in the further slides, we may need this background knowledge to go forward. So what is our status on the research now? So where the Ayurvedic research, because in the PG you are supposed to do a research study, right? And most of the researches in Ayurveda happens as a part of PG studies, which should not be the case, because the genuine research should be done by pharma companies, um, big institutes, etc. It is not the duty of a PG student to conduct serious research in Ayurveda. Why PG students should do research is to just get a knack of knowing how to do a research. So as far as my advice to you will be to select very feasible and simple topics rather than going for big studies, because the aim of conducting research in PG is just to teach you how to conduct a research. There is nothing more than that. So the serious research should be done by big bodies like CCRIS, then big institutes like All India Institute, even your college departments can do research. But it's not the duty of PG students to do serious research. Okay. So with that preamble, let us look into what is our present model. Now what we do is Shwasananda Vadi in Tamakashwasa. One drug, one disease. And we, irrespective of their prakriti, cost, etc., you give the same medicine, just like modern medicine, that what they do research. We are running behind the modern research designs. One drug, one disease. Then the so-called randomized control trials, where we don't follow any of the parameters for randomized control trial, but we call our studies as randomized control trial. I think some 4 to 5 years back, there was a study by WHO regarding all the PG studies that has been conducted in all the major Ayurvedic institutes. And they studied the type of study designs, how valid the reports were. And they were astonished to find that only 1 or 2 studies were scientifically valid. All the other studies were useless because of lack of proper methodology, lack of proper what you call objectivity of the what you call study, etc., etc. Then we do some before and after trials where we select 20 patients, we give some medicine, and we do before and after treatment. because there is no control group. These studies are not valid because we don't know whether this result happened by a chance or not. So such studies are that's what we are doing now. You just look at some of the titles. A study to assess the effect of Guduchi Kashaya in Vadarakta with special reference to gouty arthritis. So, what is the aim of such a study? See, you do Kuduchi Kashaya and gouty arthritis. Who will benefit? Ultimately, it will benefit the modern people because here there is no prakriti of the patient, no cost of the patient. Even there is no stage of the patient, stage of the Vadarakta. We don't know whether it is effective in Samavastha of the Vadarakta or Nirama of the Vadarakta. There is nothing Ayurveda in such studies. Critical study of Ega Kushta and its management by Khadira and Manjishta. You see, if you come to Kerala, psoriasis is Sidma Kushta. If you go out of Kerala, psoriasis is Ega Kushta. So even there is no unanimity in the diagnosis among Ayurvedic what you call scholars. Then how come you do a research with you? You are trying to build a house without a foundation, right? Again, you see a clinical study of some Ayurvedic compound drugs in the assessment quality of life of patients with Ega Kushta. There is no specificity, some Ayurvedic compound drugs. So these are studies that are being reported, and these studies are published in something called as predatory journals. They are not genuine journals. They just publish your studies just to make money. So they take 2,500, 4,000 rupees from you for each article, and they publish these articles. And coming to the main domain, whenever any person from modern medicine or from any other branch with a genuine research knowledge, they come and see all these things, then they will wonder what is happening in Ayurveda. So it's time to change. It's our duty to change all these things, right? See, this is what is happening. There is no foundation, but we are trying to do RCTs. We don't have standardized diagnostic criteria for disease in Ayurveda, and without having such standardized disease diagnostic criteria, we are trying to do clinical trials in such patients. So there is a foundation. There is no foundation, and we are trying to build a house without a foundation. So what is the way ahead? What can we do in such a scenario? So let us look into where we can have a change in Ayurveda. So basically, the research needs in Ayurveda can be classified into basic research, epidemiological research, and clinical research. So these are the three areas where we have to concentrate whenever we come to research in Ayurveda. So let us look into basic research. In theoretical research, there are a lot of things to be done. For example, uh, I'll tell you an example in Kerala. If you take Kerala, we have a rich tradition of Ayurvedic textbooks written by authors later than Legutrais. So we have textbooks, several textbooks that has been written in the 17th and 20th century. And all these books contain a treasure of knowledge. And we have not at all explored all those things. So there are a lot of areas where uh, we can look into the literary part, theoretical research. Then comes the new tools like bioinformatics. This we will discuss later on. What is bioinformatics and what we can do in terms of bioinformatics. Next is tool development. For example, I just told you an example of Amlavita. So how to diagnose Amlavita? This is a question, right? Some if a patient with features of Amlavita goes to three doctors, three Ayurvedic doctors may give three different diagnoses. Someone may call it as Vidagda Ajirna, someone may call it as Pitta Shula, and someone may call it as Amlavita. So why this happens? There is no unanimity because there is no standardized tool to diagnose. So we need tools. So these tools can be developed only by looking into the literary or theoretical part. Then only we can go to the clinical trials. So there are a lot of areas where we need theoretical research. Next comes applied research in basics. There are some studies known as translational studies. That means we have some textual knowledge, then we take this textual knowledge through different phases of the research and translate that into something that is clinically applicable in patients. So this is known as translational research. I will give an example. We say that Guduji is very good in Jwara. So this is some textual knowledge that we already have. And then you take this Guduji as a drug and take through different forms of studies like bioinformatics or animal studies or dose fixation studies, etc. And then you go to the clinics and give these drugs in several types of fevers, and then you find out that in which type of fever this is effective. So this process is known as translational studies. So the origin of translation study resides in basic research. So from there we have to start. Next is pharmacognosy, where identification of the drugs. So now you take the, I will give an example of even Guduji, we can say. The Guduji, which is identified in Kerala, may be different from Guduji that is identified in northern part of the India. So we don't have a consensus regarding that. You take the drug Lakshmana. Lakshmana in Kerala is something, and Lakshmana in Karnataka is something else. So you just go to another state, the identification is different. So we have a lot of things to do in such areas. Then comes pharmacological studies. We have a treasure. You take Baisha Ratnavali or any other textbook, we have a treasure of drugs, but we don't know how it acts, why it is acting, in which specific scenario it is acting. So we need such pharmacological studies. Then comes development and validation of diagnostic and evaluation tools, which I have already told. So these are some of the areas where we can contribute in basic research. Then comes the new tools like machine learning and AI. So actually, these tools can be used in case of, suppose you want to develop a diagnostic algorithm for Shula. A patient came to you with abdominal pain, and you want to create a diagnostic algorithm so that after applying this algorithm, we will get the dosha predominance of the Shula. So now you can use ChatGPT or other AI tools to develop this algorithm, or we can use the machine learning. You give patient data, use machine learning to develop this algorithm. So we have a lot of avenues today to explore. So we can use machine learning and artificial intelligence in case of basic research. So literary studies, I already told, textual analysis, comparative studies, historical research can be done, knowledge translation that I have already told you, documentation and preservation. For example, we got COVID-19 now. Suppose you take Firanga Roga. Firanga has been explained in our textbook in 16th century. So at that time, when this syphilis came out, the Acharyas were very, what they call, conscious, and they recorded the findings and they translated into Sanskrit and they have recorded it as such. So now there is no need that we should do it in the Sanskrit itself. We can use whatever language is possible. But at least the new disease COVID-19 emerged. It is our duty to document what are the dosha predominances, what were the dosha involved in this patient. This is something called as are necessary under which comes under literary studies. Then comes pharmacological. This I already told. So we need to revalidate our existing drugs. For example, we say that Chyawanprash is antioxidant. Where is the data? We just say that Chyawanprash is antioxidant. We don't have enough data. So we can what you call something called as a revalidation of our concepts, where we we use the modern techniques to study the already existing drugs. So pharmacodynamics, pharmacokinetics, toxicity studies. For example, nowadays we have bottled kashaya, and we know that all these bottled kashaya has sodium benzoate added as a preservative. So do we know that when we give this sodium benzoate kashaya for 3 months, what is the toxicity that is going to happen to the liver? We don't know. For example, I have a friend who is a dentist. He usually complains that he get lot of patients who take kashaya with staining of the teeth. They take kashaya for some 3 to 4 months, then the teeth get stained, so they go to the dentist to clean the teeth. So we don't have such studies. We just keep on writing. We say that it's there in Samhita, so that is why we are practicing that. So toxicity studies has to be done. Dose optimization studies has to be done. Standardization of the drug. Then animal studies, again another important area where we should contribute. So these are some of the pharmacological studies that we can do. Now comes studies like RCT. So why this modern drug studies model? For example, RCT means randomized control trial, where you take two groups. One is the study drug, the other one is the already existing drug group. For example, you rheumatoid arthritis. You are going to study Guduji Kashaya in rheumatoid arthritis. So what is your study population? Study population is nothing but patients with rheumatoid arthritis. Now you do random allocation of patients into two groups. One is Guduji and the other one is an already existing drug, maybe Manjishtadi Kashaya, something else, which is an already existing drug. So you take hundreds of patients in both groups. You give Guduji in one group and Manjishtadi in the other group. Then you compare the outcome at the end of the study. So this is something called as a randomized control trial. Then there is blinding, where the patient doesn't know which drug the patient is getting. So like that, double blind, triple blind studies, etc. are there. So why such research is a misfit for Ayurveda? So we know that Ayurveda is a holistic medicine where the theory itself is personalized medicine. So a Guruji for a Vadarakta patient or a rheumatoid arthritis patient or an Amavada patient with specific indicators, a specific prakriti, a specific costa, a specific season, a specific stage of the disease. So all these factors are not properly studied when you go for a randomized control trial. For that, we may need a subgroup, what you call something called as a platform trial, or something called as uh, where you allocate the patients into different strata and then you give medicines. Okay, so such studies are needed. So usually, generally, this RCT model is not fit for Ayurveda because Ayurvedic formulations contain multiple ingredients. Uh, the single drug has multiple indications, therapeutic indications. You take Yogaraj Ogulu, you have plenty of indications, right? So that is something called as polypharmacology, where a single drug has multiple pharmacological action. So complex mechanisms of action, synergy and antagonism of different drugs. So all these complex things, there are so many mechanisms in which we can study the drug action. One theory is known as reverse pharmacology. I think you can get a lot of articles on reverse pharmacology. You just take down the term reverse pharmacology. You go and refer later on. We know that Amrita is effective in fever. So we already know that. Now we take Amrita Rishta and we go backwards and we do the animal study, lab study, etc., to validate that concept. Such a concept is known as reverse pharmacology or clinic to lab approach. So we have a lot of complex Ayurvedic formulations. To study this, what we can do is you can go for an in silico model, where in silico means you study in the computer. You have a lot of software simulators now available. You do the chromatography of Amritarishta, you get all the protein components or whatever contents that are present in Amritarishta. I'm sorry for saying protein components. They may not be protein components. What are the chemical components that are present in Amritarishta? Then you load this data into a computer, and the computer will process and tell you where all these contents of Amritarishta can hit in the body, different body proteins. So these are known as in silico studies. Next comes in vitro studies. In vitro studies means we do that in the lab. Next is in vivo studies. These are animal studies and human trials. Next is ex vivo studies. Ex vivo means you take a part of the tissue outside and then you do the study. These are called as ex vivo studies. So for mechanism of drug action, we can go for in silico studies, in vitro studies, in vivo studies, ex vivo studies, etc., etc. So this concept reverse pharmacology. Please go and refer. Next comes bioinformatics. This I have already told you the term bioinformatics. So bioinformatics is nothing but the use of computer softwares to study biological systems. This is known as bioinformatics. So you can go, for example, COVID-19 happened. So when COVID-19 came, it's a new disease. So now you want to see which drug will be effective in COVID-19. So that for that, what we do is we already know the protein structure of the virus. So you take the protein structure of the COVID-19 virus, you load into the computer. Now you have the software data or soft copy data of all the drug ingredients of drugs like Guduji, Manjishta, Trifala, whatever it is. Then you load this data into the computer, and the computer will analyze it and tell you which drug will be more effective in killing the virus because of its attachment to the viral protein. So such methods where we use software simulations is called as bioinformatics. So bioinformatics is a very what you call fastly emerging field, and we can adopt this in Ayurveda. Okay, for herbal drug discovery, target identification, network pharmacology, personalized medicine. So you feed the Prakriti data and you see whether, which drug is more effective in a typical Prakriti. So like that personalized medicine, data mining, quality control of herbal products. So there are a lot of areas where bioinformatics can be used for our research. Next comes the pharmacovigilance of Ayurveda. This all Nidana people can do actually. See, we can there is no need of active intervention. You just select a patient population. For example, you have a group of patients, diabetic patients, taking a particular Ayurvedic drug. There is no need of you giving the drug. You just go to the OPD, Kajigils or whatever OPD there, and then you observe those patients forward. You see whether any adverse event happens in the patient. Is there any drug interactions happening with the modern medicine? So, like this pharmacovigilance of Ayurvedic drugs, these studies can be done by Kajikilsa people, Drivivuna people, Rasastra people, Yogadana people, even Swastavrata people can do this, because this is observing the patient for adverse event, comparative safety studies, herbal drug interactions, etc., etc. So there is something called as pharmacoepidemiology. Just like I told the example where intake of kashaya leads to staining of the teeth. So that is an adverse event, right? So a patient who is taking kashaya for 3 months may develop what you call staining of the teeth. So like this, you can go for studying the effectiveness, adverse events, etc. of the existing drugs. So these are beautiful studies, and they will give you a lot of data. So rather than blindly running behind all these randomized control trials, such studies has to be adopted. So this is pharmacovigilance of Ayurvedic drugs. Next comes studies on nutraceuticals and functional foods. So we have a lot of patya told in our textbooks. And if you see the modern medicine, they are slowly coming back to what we have told. We have already told yoga sarvebi mande agnav. What you are, what you eat, right? And now all the studies in modern medicine is related to gut microbiome, their byproducts, etc., etc. So they are coming back to our concepts. So this is where we have to rekindle the concepts that are told in our science. So you can go for studying the what you call properties of medicated diets. For example, you give Deshamule Yavago in diabetes. So how Deshamule Yavago acts in diabetes? What is the effect of that? So like that, can you market it as a nutraceutical or a functional food? Deshamula Siddha Yavagu as a functional food. So like that, there are a lot of studies that can be done in this area, especially in terms of Patya or Patyahara and Aushadha Siddha Ahara. Next is a very important area which Nidana people has to take care of is diagnostic tool development. As I told earlier, we don't have standardized diagnostic tools for uh, all of our diseases. We don't have it. So I will give you an example. Angamardo Aruji Trishna Alasyam Gauravanjala is the Lakshana of Amavada. Now, I want to ask Angamarda to a patient. How I will ask? I can ask, do you have pain in the body? So whether this one question is enough to identify Angamarda, this is the first question, right? Aruji, how will you ask? Do you have taste in the mouth? Is that what you ask? Aruji is a disinclination to food. So Aruji is a construct. So to identify the presence of Aruji in a patient, you may need to ask multiple questions. So you cannot ask, is Aruji present in you? You cannot ask to the patient, right? So like that, each parameters has to be developed into properly deliverable questions, so that when 10 individuals give the same tool to the same patient, they get the same result. Okay, so this is where standardized diagnostic tool development is very, very important before going into clinical trials. So we have to develop diagnostic algorithms. We have to standardize the evaluation tools. For example, we treat Amlavita. So Amlavita is a clinical diagnosis, right? So you give medicine, and afterwards, how will you assess whether the patient has got relief? For that, you need evaluation tools, which can identify a change in the characteristic feature, right? So these are evaluation tools. So such tools has to be developed. Then there should be studies on application of artificial intelligence and machine learning in Ayurvedic diagnosis. This is another important area where the new PG scholars can focus your studies. So diagnostic tool development. Next comes the clinical research. So we already discussed about network pharmacology, bioinformatics, etc., etc. Now is the clinical research. So in clinical research, again, we can go and study the efficacy and safety of Ayurvedic drugs. The designs include randomized control trials, other modified trial designs like pragmatic trials. So pragmatic trials means they are effectiveness trials. You just take down the two terms, efficacy trials and effectiveness trials. You just go through that. I don't have enough time to explain the difference. But as new students to the research, you please take down the term efficacy trials and effectiveness trials. These are totally different. The term efficacy is different from effectiveness. Effectiveness means something related to the real world scenario, and efficacy means that is done in a controlled environment. So effectiveness, pragmatic trials are nothing but effectiveness trials. So please go through that later on. Then there are trials like N of 1 trials, umbrella trials, platform trials. So these I have told you about Amalavita in different Pragritis, how to do a trial. So you can go for an umbrella trial. So like that, we should adopt some modified trial designs rather than running blindly behind randomized control trials. So take down these terminologies: pragmatic trials, N of 1 trials, umbrella trials, platform trials, etc. etc. So these are some of the experimental trials that we can do in patients where we give some active intervention. Then comes observational trials. This actually departments like Nidana department can do. Prognostic studies. For example, um, you are following up a patient with diabetes or metabolic syndrome. You are following them up for a period of 6 months or 1 year, and you identify certain prognostic factors that decide when the patient lands up in a complication or not. So such studies are known as prognostic studies. And then comes diagnostic studies. This you already know. We look for causative factors, etc., etc. Then comes observational clinical trials. Already your guide or your teacher is doing treatments in a particular case. You are not actively intervening. You are just preparing a case sheet and you are observing the patients and you are collecting the data and you are reporting that. These trials are known as observational clinical trials. So where you don't actively intervene. Some intervention is going on as a natural process. You just observe that and you report it. Then there is a study known as retrospective treatment outcome study. This is another easy study that can be conducted by PG students. I will give an example. You get a lot of back pain patients in your hospital. Suppose you get a lot of back pain patients, and your hospital has a very perfect and strict data maintaining practices. Okay, uh, if you have this proper documentation practices in place, this study is very easy to do. What you will do, you go and you make an objective that I am going to study the treatment outcomes of 200, 200 back pain patients who underwent treatment in this hospital for the last 2 years. Okay, so there is no need of any fresh patients. You have the records in your hand. You just take the records and you look at what is the treatment outcome. How many patients have taken treatment for back pain and what was their outcome. But only the problem is that proper documentation should have been already done. For example, you need the what you call pain score before and after in such patients. Otherwise, or you need some what you call outcome measures that has been already recorded in the patient in the case sheet. In such a scenario, it's very easy that you just take the data, you skim through the data, you take the outcome and you report it. And these are very beautiful studies that can be done in Ayurveda. We don't blindly run behind randomized control trials, etc. You just go through the existing data and you report it. These are known as retrospective treatment outcome studies. So these are some of the important studies that we can look into. So next comes the personalized medicine concept. You might be already exposed to this concept. See, the modern medicine is running behind 3 P's: personalized, preventive medicine, right? But Ayurveda has been already a personalized medicine since so many thousands of years, right? So we need to incorporate such parameters into our study. So this is where the new field, that is Ayurgenomics, came into place. You might be knowing the terminologies like Ayur biology or Ayurvedic biology, Ayurgenomics, etc. So this is one example. What is the best treatment for a patient suffering from rheumatoid arthritis presenting as Vadagafa Pradana Vadarakta, Sama Avastha, with a Kapha Pitta Pradana Prakriti, Madhyavaya, Mandagni, Pitta Pradana Koshta, Madhyama Sara, and Avara Sattva. You see how many parameters comes into play to personalize a treatment. Do we do that in clinical practice now? No. We just take rheumatoid arthritis, you give some kashaya, and you report that this is effective. But that is wrong as per Ayurvedic principle. In Ayurveda, you need to look into lot of therapeutic indicators before initiating a treatment, which we are not doing. So this is an exact example of how a personalized medicine should be in Ayurveda. So if at all you are taking rheumatoid arthritis and you are taking Guruji, then you just say that my inclusion criteria is Pitta, Vada or Pitta Kapha predominant rheumatoid arthritis with such Prakriti and such Koshta. At least that type of personalization should be brought into our studies. Otherwise, we are just doing some work for the benefit of modern medicine. If you do that, Guruji in rheumatoid arthritis, ultimately they will take Guruji in their treatment. And as Ayurvedic people, we will be dumbfounded. So this is the concept of personalized medicine in Ayurveda. Next comes integrative medicine. I am going to sum up my session. Integrative medicine is another important area where we can do a lot of role, because there are a lot of areas where modern medicine and Ayurveda can work hand in hand. So we can give Ayurveda as an add-on measure in case of chronic disease management, palliative care. For example, a lot of cancer patients. For example, in Kottakkal Ayurveda College, we are doing a lot of palliative measures, like we give medicines as an add-on for chemotherapy, for radiation therapy, and patients find it very beneficial. So we can integrate our system into other system managements wherever it is possible. Post-stroke rehabilitation, post-traumatic management. So and we can do a lot of studies in such areas as well. So integrative medicine is another area we should focus into. Then comes epidemiological research, which is very weak. This actually it has to be done by Rogadana department and Swasthavrta department. We don't know what is the epidemiology of Madhumeha in our community. We don't know what is the epidemiology of Amlavita in our community. We don't know why Sandarpanajanya Bahudosha Dushti is on the rise in the present community. We don't know why heart attack is going on, increasing in our community based on Ayurvedic principles, right? So epidemiological research is a very big area where we have to do some studies. We can go for cohort studies, case control studies. Disease profiling is another important area. I will give you an example. Hypothyroidism. Do we have hypothyroidism explained in our Samhitas? No. Do we know how or to which disease we can compare hypothyroidism? Some say it is Pandu, some say it is Dhadugada Ama, some say it is Dhadwagni Mandya. A lot of things is going on. Depending upon the physician's yukti, they will tell a lot of things. But what should have been done actually? You take some thousands of patients with hypothyroidism. You make a case sheet and you see what is the pattern of dosha involvement in such patients. Which are the predominantly involved dosha in these patients, right? Which is the important prakriti that is found in such patients, or which prakriti is more prone to hypothyroidism? We don't have data. So such study is known as disease profiling, where on already existing modern disease, which is not explained in Ayurveda, we create a disease profile by studying hundreds of patients. So such studies are very important nowadays, because whenever there is an emerging disease, we don't know the dosha predominance. An expert may tell, oh, this is kapha predominant, this is vata predominant, like that. But you know now the evidence value of expert opinion. Expert opinion doesn't have enough evidence value, right? So you study hundreds of patients and you make a data. COVID-19 is a big example. A lot of people told it is Sanibhajura. Somebody told no, it is not Sanibhajura, it is something else, like that. But actually, how it should have been done? You take data of 300 to 400 COVID-19 patients. You see what is the pattern of dosha that is available, and then you say COVID-19 is such a dosha predominant disease. I hope you got my point. So such epidemiological research is in need on our side that we have to do. Prevalence studies, disease trends, risk factor identification, association assessments, evaluation of public health interventions. For example, this Swarna Prasana is a big trend now, right? All the Ayurvedic institutes, colleges, etc., they conduct Swarna Prasana in kids. Why don't you study the efficacy or effectiveness of Swarna Prasana in such patients, such individuals, not patients, such individuals or kids who underwent Swarna Prasana? Why don't you study that? So you can evaluate public health interventions. There are a lot of scope for epidemiological research in Ayurveda. Disease profiling, I already told. Then comes secondary research. This area is not that much looked into because the primary research is very weak in Ayurveda. If you have primary research data, then you can go for a systematic review. This is known as secondary research, where already research has been done and the data is published. Now, you take the published data and you try to do research on that data. So this is known as systematic review, and the statistical analysis is known as meta-analysis. Just go through this later on. What is secondary research? So these are some of the core areas where we lag behind: long-term retrospective studies, pharmacovigilance of Ayurvedic drugs, epidemiological studies, diagnostic tool development, disease profiling, integrated medicine research, secondary research, and documentation. I will pause for 1 minute so that you can take this down. Take this down, and whenever you plan for your research PG synopsis, you please think about whether you can do something in any of these areas. I will just pause for 1 minute, then we'll conclude the class. Okay. Again, I would like to conclude that don't go and take big studies which cannot be feasible in a PG study. Just go for something that is very important, where there is a knowledge gap. Take some simple studies, but with proper methodology. So this is my message. Good luck for your PG studies. And I once again thank the college for giving me an opportunity uh, to address the new PG students. Thank you, Sarita Madam, once more. If at all there are any questions, I can answer them. Yes. No, actually, such epidemiological studies, the sample size has to be calculated based on the prevalence of the disease. So if it is a rare disease, no, that's what I'm telling. Disease, no, disease profiling is also an epidemiological study. So, for example, if I want to do a disease profiling of a rare disease, then I need only a very small sample size. But if I am going to do a disease profiling of a widely what you call prevalent disease, I may need a high sample size. So the sample size is calculated based on the prevalence of the disease. No, this 30 is a what you call this 30 is a very big what you call um, actually it's a very big no, it's a very big mistake because 30 whenever you do some statistical test, the software needs at least 30 patients to take and process it. That is why we are doing it 30. Uh, But but that is a very big mistake that we are doing. Actually, there are two ways in which we can identify the sample size. One is based on the prevalence of the disease, or we can take the sample size from the previously reported studies. These are the two ways in which we can take the sample size. This is what I told. See, the disease profile of a hypothyroid patient in Odisha may be different from that in Kerala, right? Yeah. Uh, but when you come to Kerala, no, here in Kottakkal College, we get like hypothyroidism on a daily basis. Plenty of hypothyroidism, right? So even that type of study is very valid. A student can just study what is the type, what is the most prevalent disease that comes to your college. That itself is a study. Because see, I will tell you an example. I am a very big businessman, and I want to start a big Ayurvedic drug company. So what will be my question? Which is the highly prevalent Ayurvedic diagnosis for which I want to develop a drug? Because I want profit, right? But do we have such a data now? No, we don't have any data. So this is where we Nidana, Swasthavrta, etc. department has to study the epidemiological part. We don't know how many bike riders they get Kadigraha. We don't know. we don't know why certain bike riders get Kadigraha and not others. Because they may be having more Pakvashekatavada. That is why they are predisposed to getting disc prolapse. We don't know. So we just study individuals who are riding bike. You just follow them and see how many of them have back pain, how many of them has Pakvashekatavada. This is a study. We always run behind RCT and we don't do it properly because that is not feasible in a PG study. And finally, we land up with a data which is not valid. But we just take one simple thing and you do that in a particular proper methodology. We have a very good thing to publish. No. Actually, when a researcher has the freedom to select which condition the researcher studies, right? So you make a proper tool to diagnose Pakvashekatavada. That is enough. Yeah, that's enough. That's enough. Yeah. No. Yeah, the sloga is not enough. You have to convert that sloga into a deliverable tool with a proper face and content validity. Then only you can use it for the study. So you have to develop. The development of a tool to diagnose Pakvashekata Vada itself is a big PG study. Yeah, yeah, sure. Good evening. Definitely. See, why I'm telling this is because my PhD study is on a tool development to diagnose Grahani dosha. Okay. I will tell you my experience. I first prepared this tool by conducting a focus group discussion of 6 experts from Panchakarma, Nidana, and Kajigisa. Okay. Because these are the people who are dealing more with Grahani dosha. So I first initially did a focus group discussion. I took their inputs, then I prepared a tool. Okay. And this tool had 13 items in the tool. Then what I did is I did something called as a cognitive interview. In the cognitive interview, when we interviewed the patient with this tool, I found out that different doctors are delivering each question in a different way. The same question is delivered to the patient by different doctor in a different way. And it doesn't mean what I have intended. And when the patient hears the question, the thought process that is going on in each patient's mind is different for the same question. Then I had to refine that question several times. Then there is something called as inter-rater reliability, where you develop one tool and I use that tool in a patient, and then another person use the same tool in the same patient. You should get similar values. If that is not similar, then there is no validity. There is no reliability, right? So it has to go through that meticulous process of validation and testing of reliability, then only it can be used in clinical practice. Otherwise, what happens? You just look at all the tools that are available in all these rubbish journals, they are useless. Yesterday, I have seen a tool for Pakvashekatavada, something like that, where the term Vibanda is used. The question is Vibanda. Okay. So, how I will ask Vibanda to the patient? Do you have constipation? How it is a frequency? Is the stool hard? How many questions I can ask for one parameter? Isn't it? So a tool should have items. There will be constructs, and for each construct there will be multiple items. Only then it will become a pro. And whenever two or three individuals are giving this tool in the same patient, they should get at least comparable results. This is first thing. Second thing, the same tool, when given in the same patient on multiple intervals of time, should give the same result. This is known as test retest reliability. This also should be there. So there are a lot of parameters which the tool has to go through. Then only we can consider it as a properly validated tool. No, I know. No, I know that. No, I know that most of the things that I have told might have gone above their head, but at least you just this will be an eye opener. They can explore into some things that they have not heard about. Thank you. Thank you. Thank you. Sure, sure. With pleasure. Yeah, yeah, yeah. Thank you. Thank you. Yeah.